Our next case for the session is a 47-year-old male having history of hypertension and diabetes, presented with acute inferolateral wall MI, good LV systolic function, RCA showing insignificant disease, LCX showing thrombotic total occlusion, primary angioplasty to LCX has been done, and LAD is showing 80 to 90% lesion in the osteoproximal part. Syntax score is 13, and our plan is to do robotic assisted PCI to LAD. Now watch live.
Dr. Sanjay, you're on.
Yes, yes. You have already cannulated left coronary. Just show the picture. Two views we have taken. Next. And we have already loaded cassette with guiding catheter, PTC balloon and PTC wire. So we are ready to go with robotic PCI now. Tejas will.
Hey, Sanjay?
Yes?
Park here. So you intend to treat the osteo LAD or
Yes.
the mid LAD is some disease.
So,
Are you
osteal
planning
has
to treat
some
that?
disease. Next view, in epicaudal it is seen. I think we can start stenting from just at the ostium and avoiding bifurcation type of stenting in this case. It looks like.
Okay. So what is
no,
your
just everything is loaded.
what is your strategy?
The strategy is to stent LED only.
Yes.
Yes, yes. No,
How
but-
you stand the osteo LAD? What is your strategy? Stand at osteo.
Just flush with the ostium, and I think it will be okay.
So you think there's enough room to place a stand right at the osteo?
Yes, just half or 1 millimeter from the ostium.
So
Attack, we are not going to show
So
very
you use-
difficult cases for the robo. It will send wrong signals. We are just discussing the feasibility of robotics in the intervention.
No question here, Tejas. Where would you put your
Epicaudal.
stand strut? In the 3 o'clock position or 6 o'clock position?
Let me wire first, and then I'll tell you. Scout. 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 Scout, no. Sanjay, I need to.
I think cow. You want little more cow on wire?
Maybe. Scout. Or I may go to LAO caudal view.
Okay.
Scout. This is a better view. And I am rotating my wire. Scout, no.
can TJ talk here? Can you push the guy in using the robot?
Yes.
We can, but in the left I am not, I don't want to show these in live. It can be done. Sanjay, what we need to do is to give a secondary curve, tertiary curve to the wire.
Okay.
Let me try.
Little withdrawal of guiding.
I think so. Okay.
No.
I am withdrawing the guide little bit. Scout.
Yes, yes, this is better. This is.
Just show me. Can push little bit.
Slowly.
Okay.
Okay.
Scout.
Or we can make it loop by sending in circumflex. So second curve will automatically come.
Yes. You saw what I did.
Scout.
Tuck.
Yes, I saw it.
Yeah. I went deep in the circumflex and all the time I did a counterclock rotation to the wire to enter. Scout. Oh no.
Now it will go.
This is a stupid mistake. Anyways, again, the same maneuver. Sanjay, you might have to give the curve.
Discharge circle we can deform the wire.
Yeah,
if
that's
it is
right.
okay. This is
good.
जाओ दो जी अंदर.
Guide bar also.
Yes.
The wire is not getting deformed. I want to deform the wire. Curve. I think last chance I am taking and then we give the curve. Sanjay, સામે પછી તારે ક્યારે જઈશ તું?
હવે ત્યાં મોરેશિયો વાળો કેસ છે. OM bifurcation LED.
Last chance. Then
favorable लगा.
it has a tendency to go in circle. Now I will push my guide in.
Scout.
Scout.
It's out.
No. I don't think I will struggle anymore. We'll change the shape. And you guys might be feeling that why am I struggling? You know, but this is a new technology. Any new technology has a price to pay. You have to, you know, go through this process.
I'm removing, huh?
At any, yeah, should I remove it? Okay.
Okay.
So, out of many different things that's changing here, Dr. Patel, we rely on so much on tactile feedback. How did you come over that lack of tactile feedback working with this?
I take help of balloon, you know, wherever I really am interested in my tactile feeling, yeah.
I need it. चालू वो राइट करना था एक नीडल ने पास
Is the left side guide cannulation as is it something very similar to how you did it on the right coronary
No,
demonstration?
it is little more tricky, that much I can tell you. And that's why I don't want to show the left cannulation in live. It can be done. So we are also trying to set the standards of Robo. My purpose to do several cases during the course was to introduce this technology to the young people of this country and surrounding country, young cardiologists.
weight goes
Sanjay, are you shaping the wire?
already given, now we are loading it.
So as of now, this technology is only for the coronary space.
We have done renal stenting, that is a off-label indication. We have done renal iliac, you can do, no problem.
I think that's where the advantage would be a lot, particularly for the lower extremity endovascular procedures. Those are generally speaking long.
Scout.
Yes, out.
This point of time, I may pull my guide a little back.
Teacher,
Scout.
when you manipulate the why the guy is any delay?
Yes, it has
Oh,
gone.
you got it.
There is an angle in LAD, so
Millimeter by
millimeter by millimeter I am going.
balloon, balloon.
Balloon nakelu?
You think cranial view will be helpful now?
Balloon will be helpful.
सर्कमा जतो रे बाहेर कदाच
But I keep the balloon here. There is lot of tension on the wire. It's moving. Oh no. Okay.
balloon.
Guide is coming
balloon,
out.
balloon, balloon. Yes, now we are in business. Now the balloon was yes.
Go to AP cranial. So many people will be happy, young guys will be happy seeing me struggling with this lesion. No problem. Record. Life is a struggle at every stage. Fine. Oh, sorry. Sorry. Scout.
Yes, fine.
Okay. Record.
Directly.
Scout,
Yes.
record, go up 10, 11, 12. Yes.
So how precisely can we rotate?
That's what we are trying to establish.
I see.
Because sometimes what happens, if there are more angles in the coronary, I rotate only one side.
I
It doesn't follow clock counter clock. If it is straight segment, it follows clock counter clock. So we are trying to figure out
I
those
see.
things. Yes.
Deflect.
Deflect. Go scout.
सर तो proximal यहाँ पे जो बच्चे ना segment normal.
10-15 मिनट इंदरमल. Scout, go up. पानी पिउड़ाओ हमने. चलो, give him some water. Okay. Scout. Epicaudal now. Scout.
बस.
Go up.
Ostium छोड़ के. नहीं ostium छोड़ के.
कहीं ये जरा रखना.
Perfect.
14. Come down. There is an angle. Just see. There is an angle.
हाँ हाँ. 6 मिनट अब बताओ आप line.
बतावानु છે. એ scout. Okay. So I come out. Inject. Okay, go to epicranial. There is a big area of ectasia in between. What to do? Tuck.
So I think you're going to stand the
Very
mid part first and then
I am going to use one stand in the mid part and then the another one.
another stand in the osteo.
Let us see. 3 by, this should be 3 by 18
3 by
or
23.
22. 3 by 22 onyx. Onyx.
That diagonal,
Go to-
you think you don't need to protect it?
No, no, no. It's okay.
Do you plan to overlap the two stands?
That Sharad I will decide once I deploy the stand. That I will decide. Go to epicaudal.
हाँ.
Balloon
बस balloon remove करिए.
removing. This is a turbo.
Okay.
Bus.
Ciao.
Okay.
So, you have done already many cases using this equipment. How about advancing a longer stand through the more acute angulation? Is it
You
just
have to-
fixing of the guide helps?
It helps. Sometimes 2 wires, sometimes fixing of the guide. See, wherever we find problem, we try to take support of all those basic techniques we have learned so far.
So we can use 2 wires through this this device through the robo.
Yeah, there is an auxiliary track where you can use another wire. But then that wire remains manual. That robo does not maintain. You got onyx? After this case, the next case which Mauricio is going to do, Sanjay is again going to demonstrate the distal radial approach puncture, because the first puncture was done at that point of time, many must not have seen. So yeah, we don't want you guys to go out of the auditorium till lunch. Rajiv, you saw this angle is bad, and yeah, and for us it is the best thing is I am sitting here without any laid up apron or anything.
Stent loaded.
Stent loaded, enable all. This is turbo. I have taken onyx because of these angulations. This is one stent I can trust.
Epicranial.
Yeah, Scout. Am I? Yeah, good. Epicranial. Scout. Okay, record.
Perfect.
No?
It's okay.
Okay, now again. Scout. We will overlap. Huh? Go. 12. Onyx will expand little more. 14.
I think okay.
Record and come down. We'll go up again. Go up again. 14. Come down. Should we measure? Let me just pull this balloon back. This was 22, right? Record. Okay, show me epicaudal or LAO caudal. Here you can see that you can spare the ostium, I suppose.
Dilatation here also.
We will dilate this area, yeah, with this balloon. Record.
Yes, 28 ले ले इसको
28 ले. So go up here, 6, 7, 8. And then we might have to dilate the middle part with 3.5 balloon, right, Rajiv? 10, come down. There is an ectasia. So if I am dilating it with a bigger diameter balloon, I will be careful, I will not go very high. Come down.
What about, what do you think about advancing the balloon a bit more and proximal optimization because of that angulation so that the second stent goes in smoother hopefully?
Pardon?
Proximally optimize this first stent with a higher pressure.
Let us see. Record. You saw there is an angle. And this looks good. So now I am pushing this turbo button to remove my stent very quickly out. Okay.
Stent.
3 by 28 or 3 will be very big in the for the ostium, Sanjay. What do you think? What is the opinion from the audience?
I think it will be at least 30 plus.
What?
30, at least 30 millimeter plus.
No, diameter.
3 or 30.
330, 3
And
at the
then post
ostium
diameter.
will overstretch.
I think
Too
3,
much.
5.
But you put 3
Pardon?
You put 3O in the mid, right?
Ostium थी चालू कर दे इसको वांदो नहीं.
Or else, can you spare the ostium?
No, I don't think so. I think you have to put a stent little bit into the left main.
Back.
So that is what the question I asked actually. You will
Yeah.
put the stent strut at 3 o'clock or 6 o'clock position in that origin.
Even the putting in the left main also next.
One side of the stent has to be in the left main.
32 होंगे, 30
30,
30.
30 or 32, onyx 3.
So you put 30, 3030 or 3530?
3. I will be playing little safe. I'll rather dilate with a 3.5 balloon rather than straight away going ahead with 3.5 stent here.
I think good idea. So what I see so far, removing is very easy.
Yeah.
It would have been easier if you'd have played with some Nintendo in the high school also.
34. 34, will it be little longer?
Yes, it will be longer.
30.
I think 30 is quite okay, and left main is capacious, so
There is a big
size
angle
won't be a
between left
problem.
LMC and LAD and circ. So yeah, it is still okay, even if. And the circ you saw, we have stented in acute MI. It was all thrombus there.
Wait.
In fact, that circ flow in the last procedures, angiography versus now, what you were talking about, the inflammation in the circumflex during that acute MI was like outrageous. And now it looks so much better.
Let me ask you, in India, when you have a STEMI, what proportion have multivessel disease? It seems that many of the patients are coming back.
More than 50%.
More than 50% have multivessel disease. Yeah.
3/34 है Onyx.
तो ले लो 34 if the size is not available, because I will be sticking to Onyx in this case because of the angle. I will trust either Onyx or Zero to cross this angle.
So while we are waiting loading of the stent, what do you think about revascularizing all disease vessel at the time of primary PCI versus only the culprit lesion, Dr. Patel?
Revascular at the same time?
Yeah.
Everything?
Yes, that British paper.
I am little hesitant, because if the patient has a tendency for clotting, and if at more than one places the thrombosis happens, you are in deep trouble. So I will, even if I want to do complete revascularization, in the same hospitalization, I will do culprit and wait, and next day I may, or maybe in the evening, if everything is fine, I will do. Rajiv, what is your opinion?
Yeah, we would typically stage the second intervention as well. There's a few trials that will be addressing these questions, but we would typically stage. Dr. Akasaka, you do multivessel
3.5 no ek balloon.
There are some
Loaded,
discussion. Previously, the same day procedure is guideline made class 3. Now the class 2B, still class 2B. But there are several studies showing the better to do the Lesion procedure at the same time, at the same day. But still to be,
looks
I
good,
think. And only the advantage of the
10.
Non-culprit lesion treatment,
12.
we can save the
12.
second admission and save the new catheter and yes. So
again,
just only the cost effectiveness, only a little bit. So still we need much more data.
12. Come down. I think I wish I have not pinched the circumflex. Okay, go to epicranial. Sanjay, ectasia वाला portion. You can dilate here. 12, 14, 15. 15. Maybe we might not require. We might not require, because this balloon is expanding differentially. That's fine, completely. You can go up, once it deflates, you can go up again. Go up. Come down. See, I am pushing the balloon in. Oh no. I am pulling the guide also back little bit. Okay, AP.
Push guide.
निकली गई.
No, it will go. It will go. Fine.
Okay. Okay, now go to LAO caudal. LAO caudal. Record.
Nice.
This looks fantastic. Anything needs to be done, Rajiv?
Epicranial.
Epicranial. Now please don't prompt me to do anything. Enough.
Robert is tired.
Yeah, record.
Yes.
This looks great.
Great.
One AP caudal. Sanjay, you can scrub there and make Mauricio scrub. Meanwhile, I will continue with a couple of minutes discussion here.
Can we move the guiding catheter, guiding wire, and, separately?
Yeah. I'll show you that.
Yeah, right.
I want to show you that. Now, go record. Let me record the views first. Fantastic. I am removing the wire.
Yes.
Now I will show you how safely you can remove the guide. AP. I mean, when I am removing guide, just show here. I am pulling it back and giving a counterclock rotation. And I am out.
I see. Right.
So any questions you guys have?
Yes, Dr. Patel, this is the nice representation of robotic angioplasty.
Yeah.
And I have few questions to you.
Yeah.
One thing, you are doing these plastics with the remote control, and the knobs are quite good, quite large size, and the wire balloon, or these are low profile things. So how far you are comfortable with controlling from this remote knob to those situations, your feelings, and are you feeling very much comfortable, or still you are hesitant to do all these things and carefully operating the instrument?
Good question, good question. Any new technology, let me tell you, or technique which I have adopted and imbibed in my career, when I start something new, myself and Sanjay, we make it very clear that we are students and we will do step by step. If there are 10 steps of any procedure, I will not like to skip any one, despite my experience of doing more than now nearly 100,000 cath lab procedures. I will not skip any step. Once I start becoming comfortable, I become little faster in some of the steps. Like in radial, if there are 1 to 10 steps, 1, 2, 6, 7, 10, that I do. I never skip any step. Whenever I am using a new technology, I will strictly adhere to the rule of the game for many cases, till when I feel that I have enough experience and I have completely surmounted my learning curve. Professor, what is your comment on this?
Yeah, I agree. Yeah, it's the best way to learn the new technique, right?
Yeah.
Yeah. And may I ask another question? In the daily clinical practice, sometimes if the balloon difficult to pass to distal, sometimes we pull out wire a little bit.
That's right, and it goes in.
Yeah. So using this machine, is it?
This is what? Yeah. Sometimes I play with all these 3 knobs. So I just push this back. Pull little back this and push it in. I play. So it is basically hand-eye coordination, and it is a coordination movement with your fingers and hands.
Great.
Yeah.
Great.
How is your experience in doing complicated cases with this?
We have started indulging into encroaching upon the difficult domains, like some good CTOs with good nipples, some multivessels, acute MIs, and Sharad, as we do them, we are very careful doing them without. See, my first and foremost, goal is I want to make procedure safe for my patient. So if anything compromises safety, I have no hesitation converting into a hybrid procedure, and I will straight away, use my hand and keep the robo away. Initially, in difficult cases, we had to go for hybrid, maybe in one out of 3 or 4 cases. Now that number is going up, now 1 in 7 or 8 cases, something like that. So, secondly, procedural time at the moment is much more as compared to the hand job. Maybe little bit of more contrast at the moment, but with time we have seen that the contrast load, radiation time, everything is going down.
Yes,
similarly, robo preparation time, we are measuring every case. Robo preparation time, what Yash and Sanjay showed you, that has also reduced remarkably. But there is a learning curve, and you have to surmount the learning curve. Secondly, there is a scope for new developments, new software to come. But this technology, the future seems to be bright, particularly, and that is what I am discussing even with the company, that we have to make sure that it becomes so simple that everybody can do that. There are some devices and technologies which are excellent, I would say, but they are difficult to use by the young guys or inexperienced guys. The device which I consider versatile is the one which can be used by everybody at their particular skill level very comfortably. Rajiv, any comment on this?
No, I agree. This simplicity will make this successful.
Yes. You have to make the procedure or technique or technology looking simple, practicing simple, then only that technology will have future. And I am sure that, this particular technology is going to enjoy a bright future. And because we are the initial users, we are actually, at the moment, we have to work hard. We are the guinea pigs in the system, but no problem being guinea pig for this. Thank you.
Sir. We are ready in the next room, sir. Thank you, sir.
Yeah, sure.